All right. Well, I want to thank everyone for participating today, for signing in, and welcome to our June 2019 Telewell Project webinar. The webinar this month is the treatment of pain in the MAT patient. This is a very common clinical scenario that I'm sure a lot of you see every day in the clinic. And as we'll see later on in the slide, or later on in the presentation, this occurs, more often than not, that you have an MAT patient also with pain issues. So let's go ahead and get started. Okay. So this is the outline. I'm going to start with talking a little bit about the analgesic potency of buprenorphine, some of the common uses of buprenorphine as an analgesic. Going to talk some about the treatment of acute pain in an MAT patient. That's a frequent question that I get from patients, of course, because they're worried about, what if I have to have surgery or, get in an accident, how am I going to be treated? We'll talk about treatment of chronic pain in the addicted patient. And then we'll talk a little bit about the use of adjunctive treatments. This is going to be a relatively short webinar, as there's no codified guideline for how to do this, and a lot of times it's best to discuss in the context of a clinical case. But this is our didactic webinar. We have clinical case discussions on every first Wednesday of the month. So let's go ahead and proceed with the presentation today. So starting with the analgesic potency of buprenorphine compared to other opioids, buprenorphine is very, very potent as an analgesic. And we look at potency in terms of the milligram morphine equivalents. So basically that it's kind of a common way to compare one opioid to another, putting it in terms of the milligrams of morphine that it would be equal to. And the CDC guidelines recommend that folks that are not treating addiction to use caution when they're going over 40 or 50 milligram of morphine equivalents for treatment of chronic pain. Some of you may be familiar with these new guidelines. And in CURES, the CURES system is alerted whenever a patient goes above 90 morphine milliequivalents. So part of addressing the opioid crisis is trying to get providers to prescribe opioids in a safer fashion. The typical buprenorphine and naloxone morphine milligram equivalents often exceed this amount because of the potency, but because it's unlike standard opioids, you don't have the same types of risks that you do with the standard, with any other opioid. So you may get an alert on the CURES system, but because it's the morphine milligram equivalent is over 90 only for analgesia, it doesn't necessarily translate into being more unsafe. So here are some conversions And so in general, 1 milligram of the buprenorphine film or tablet is equivalent to 30 milligram of morphine equivalent. So if you have, if you start a patient on 4 milligrams, which is the standard induction dose, that is the analgesic equivalent of 120 morphine equivalents. And so theoretically, starting on the most conservative dosing of buprenorphine, you're already giving them significant analgesic relief, at least kind of in a standardized fashion. The patches, they basically are, their strength is expressed in micrograms per hour through the transdermal system. Then let's see, I think I got it on the next slide. Actually, let me go back to this one. I just wanted to point out that that morphine is here on the bottom, and as you can see, just to explain this chart a little bit more, morphine equivalent to 1 milligram, of course, that's what we're measuring, which is also equivalent to 1 milligram of hydrocodone. So hydrocodone and morphine have a relatively equivalent potency analgesic wise. Hydromorphone dilaudid is much stronger, and as some of you know, oxycodone is a little stronger. Oxymorphone, Nucynta, that's also stronger. So just going over some of the more common pain medications that are out there. So let's see, this is pretty much the same thing. So let me so I'll go on to this slide, which this describes some of the benefits of buprenorphine as opposed to some of the other opioids, and what a patient may benefit from as you're transitioning them from a traditional opioid onto buprenorphine. One of the things is that there's no ceiling effect for analgesia like there is for the euphorogenic effect. So one of the nice aspects of buprenorphine for treating opioid use disorder is that beyond a certain milligram, and in most researchers put it at 30 to 40 milligrams of buprenorphine, there's no additional euphoric effect from taking more. So there's really no motivation for people taking more buprenorphine. So it's ideal in that sense, which is very different from all the other opioids, where more of the agent gives more of a euphoric effect, which reinforces itself and leads to these ever escalating doses. Now, that doesn't hold true for the analgesic effect. So we'll take that example before, if you're inducing someone on 4 milligrams of buprenorphine, which is equivalent to 120 milligrams of morphine, theoretically they'll get that amount of analgesic effect from that 4 milligrams. But if you go up to 8 milligrams, that should give you 240 milligram equivalents worth of analgesic effect. And if you say you double that again, that's equivalent to 480 milligrams. So it's equivalent to a lot of morphine, basically a lot of morphine in terms of its analgesic effect. It causes less hyperalgesia. I'm sure most of you have heard about the opioid-induced hyperalgesic effect that occurs with folks that are being treated chronically with opioids. Basically, there's a downregulation of the pain receptors, and people basically become more susceptible to painful stimuli. And buprenorphine does not do that, which is, or at least does it to a much lesser extent. Buprenorphine is better for neuropathic pain. As you probably know, the traditional opioids are not that great for neuropathic pain, and buprenorphine is indeed better. And of course, one of the most important aspects of buprenorphine, as opposed to the other opioids, is that it's much safer. There's less respiratory depression, and deaths from buprenorphine overdose are very rare. When they do occur, it's almost always in the context of lots of benzodiazepines. There's a lot less constipation. I've seen it many times where someone may come in and they're using heroin and they haven't gone to the bathroom for a week, but and that's their pattern. But in starting them on buprenorphine, their bowel habits become much more regular. There's a lot less cognitive psychomotor impairment with buprenorphine, less immunosuppression, and less hypogonadism. And that's an important thing to discuss with all your patients, but particularly some of your young male patients. That may be very compelling for them. So these are some of the formulations that are available for pain of buprenorphine. There's some, as I mentioned before, there's a transdermal product. It's called Butrans, and it's the sizes are rated in terms of micrograms per hour. The oral formulation, it's a buccal formulation. The name is Belbuca. It's recently become available, and it comes in 2 and 8 milligram strips, and instead of putting it underneath the tongue, it goes basically the side of the cheek. And one of the things that's important about this one is that it has a slightly shorter half-life than some of the formulations that we use for MAT, so it is maybe a little bit better for pain, and we'll talk about that a little bit later. And then there's parenteral formulations of buprenorphine that's used primarily in the hospital. So moving on to what happens if your MAT patient gets in an accident and they need quick analgesia, or in this case, they go in for surgery. How is that managed? There's several approaches that are possible. One is to increase the dosage of buprenorphine. Again, very powerful analgesic in its own right, and many times is adequate if you increase the dose. Also, giving it more frequently, giving it QID, it seems that tends to give better pain control in treatment of OUD. Buprenorphine should be given once a day in order to avoid basically the pill taking behavior, and try to deprogram folks from that. But for pain, it really does seem that multiple dosing is more effective. You could Another option is you could continue the buprenorphine and then titrate some short-acting opioid analgesics in. This is a little bit tricky because of the antagonism that buprenorphine provides. Pharmacologically, it both stimulates the mu receptor as well as blocks it. So it's kind of tricky to decide how much opioid analgesic is going to be able to overcome the blockade of the receptor. Another option is to discontinue the buprenorphine the day prior to the planned procedure, and then use short-acting opioid analgesics in the interim, in the perioperative period, and then induce the patient into their MAT program right away. So, so we talked a little bit about treating acute pain in the MAT patient in the situation of having a procedure. Well, what happens if they present to the ER? Let's see, let's go forward. Oh, there we go. Okay, whoop, just slow. So the options for an acute injury are similar as the procedures for for a planned surgical procedure, other painful procedure. But there's a few other things to consider. First, consider the severity of the pain and whether just adding an NSAID or Toradol might work. Opioids aren't first-line therapies for any minor injuries, and of course you want to take the conservative route first. But if the pain is severe, if someone has shattered their fibula or something like that and is in a lot of pain, then you can change the dosing of the buprenorphine more frequently, and then as in the case with a procedure, you can increase the dose. If the pain continues or there's a severe pain with the injury, someone with a femur sticking out of their thigh, you can kind of overcome the antagonism with short-acting opioids, although I would want to do that in consultation with an anesthesiologist. Okay, so moving on to treatment of chronic pain in the addicted patient. So we're going to talk about the person who has been diagnosed and the patient who has not been diagnosed, and how to deal with chronic pain in those cases. So it's very, very common for folks with opioid use disorder to have a chronic pain condition. As a matter of fact, chronic pain treatment is a very, very common method or antecedent to opioid use disorder. A lot of folks are, started on an opioid. It's not the opioid pain management is not managed very well. The provider doesn't keep close enough tabs on the management, and then the person gets addicted. There's some statistics that the presence of chronic pain in patients entering MAT is about 50%. There's a range 40 to 60%, but about 50% of all MAT patients also have some sort of pain condition. And then for folks that kind of looking at it from the reverse, for folks that are in primary pain treatment, the presence of misuse of opioids is pretty common. And this the just what percentage of those folks in pain treatment are misusing their opioids really kind of depends on the population. Some of the specialty pain clinics maybe a little on the lower end, but in uh, a safety net clinic where you have a lot of folks with a lot of mental health issues and lots of medical issues, the rate is going to be higher. Patients who experience flare-ups of pain during treatment, they're prone to relapse, so that's something to definitely look out for when when treating folks for pain. We briefly mentioned opioid-induced analgesia before. This is a state where individuals who have been on opioids for some period of time end up becoming more sensitive to pain, and sometimes it even turns to allodynia, which is folks that experience pressure or some other stimulus that's not necessarily considered to be painful as a painful stimuli. So like pressure, they may experience pressure as being painful. And this is a very overlooked complication of opioid therapy. And something that really needs to be looked out for. So what to do about opioid-induced hyperalgesia? What are your options? You could, well, first of all, cessation of opioids sometimes reverses the downregulation that's occurred. After someone is off of the opioids, starting on low-dose naltrexone, and again, naltrexone is an opioid antagonist, but providing that at low doses on the order of 3 to 5 milligrams can actually reset some of the pain the pain sensing networks in the brain and reverse the hyperalgesia. That it's been used in fibromyalgia patients for quite a while. It generally has to be made special by a compounding pharmacy, since it does not come in that small of a dose. Generally naltrexone comes in 50 milligram tablets for alcohol dependence or opioid use disorder. And so you got to have it made specially, but it does come in a powder, which a compounding pharmacy can use to make you low-dose naltrexone. It's been found that NMDA antagonists also can decrease opioid-induced analgesia. These include atomoxetine and dextromethorphan. I'll just briefly mention I had a patient that I was treating for depression and anxiety and ADHD, who also had pretty severe peripheral neuropathy that kept him up at night and so forth. I had started on gabapentin for the anxiety, which helped some, and helped some with the pain and anxiety. But then when I added atomoxetine or Strattera for the ADHD, the pain got a little bit better as well. So so that can be helpful, and the person had been on opioids in the past for their peripheral neuropathy, so had some opioid-induced hyperalgesia, and fibromyalgia was actually a diagnosis that this gentleman had. And then both methadone and buprenorphine have the NMDA antagonist effect, and they can also reduce the risk of opioid-induced hyperalgesia. And I mentioned in the beginning discussing some of the benefits of buprenorphine as opposed to the traditional opioids, that this is one of the advantages, is that it tends to not produce opioid-induced hyperalgesia. It's being stubborn. Let me make it go. Okay, so how do we determine which pain patients are addicted, number one, and how do we safely treat both conditions? So we're going to touch on both of those, but as I mentioned in the beginning, there's not a great there aren't great guidelines on this, and it can be tricky and difficult, and requires a lot of judgment on the part of the provider. So some of the difficulties of teasing out pain and addiction are that both severe pain conditions and addiction can have a severe negative effect on a person's function and behavior. They can both decrease a person's concentration and mood, and can affect their work productivity, cause some social isolation and withdrawal. So that there's that similarity. Both can contributed to drug-seeking behavior, and there's a term for this, pseudo-addiction. So it looks like someone is maybe addicted to medication, but it's actually their pain is being inadequately treated. Now, this was probably thrown around excessively in the 90s when they were telling us that we were under-treating pain. But it does nonetheless occur sometimes. There is an overlap between some diagnostic criteria for addiction and the usual physiologic effects of opioids on the central nervous system, namely tolerance and withdrawal. So that's going to occur. Tolerance and withdrawal are going to occur as a neuroadaptation regarding or regardless of why a person is taking an opioid. But we also see this in addiction too, so that can be a little confusing. And then another aspect of it is that it's been shown that pain actually elicits a dopamine-based reward. So not only does an opioid decrease pain through peripheral mechanisms, but it all peripheral and central mechanisms, but it also reinforces itself, because the relief of pain is one of the basically ways we've developed. And if you go to the evolutionary biology of the reward system, I've heard patients ask, so why would we be created with a system that makes us want to use lots of things that are bad for us? And basically it's was developed. It exists in all vertebrates, and it reinforces behavior that helps with survival. Excuse me. So procreation. It's been shown that procreative activity increases dopamine by about 200% over baseline. And then calorically dense foods, or some things that are that you like particularly, very tasty, those can increase dopamine by 1.5 times over baseline. And then we don't have a good, clear idea of to what extent it increases dopamine, but we do know that avoidance of pain does give a dopamine burst, and this was shown in rats. Basically, they they applied capsaicin to the skin of shaved rats, and then with very teeny monitors and scanning afterward, they determined that the caps that when they were able to relieve the burn from the capsaicin, there was a dopamine release. So that was one of the first indications, and that study's been replicated several times. So it's pretty well established at this point, and sort of makes sense that that would be a behavior that we would want to that would be propagated, staying away from painful things and relieving pain. Okay, so depression and anxiety have a huge effect on chronic pain and the way pain is experienced. One of the things that you know, that I tell folks is that pain is pain, and a lot of folks have trouble differentiating their physical pain from their psychic pain, and there's a tremendous amount of interplay between the two, and this can make things difficult. You know, it's been long recognized that there is a link between pain and depression. There was an article in the early '80s basically proposing that chronic pain be established as a variety of depressive disorder. That never happened, but that's just to kind of give you an indication of the close link. You see many of the same neuroendocrine disruptions with chronic pain patients and depression patients. They've done psychological testing on chronic pain patients and depressed patients, and they've found that relative to controls, they both share the psychological excuse me, something popped up. The psychological symptom or psychological defense of a feature of catastrophization. Basically perceiving a problem or something noxious to you as being much worse than it actually is. So that you see that in both chronic pain patients and depressed patients when you do psychometric testing. Also, functional MRI studies have shown that you have increased rumination related activity in the medial prefrontal cortex, so in the middle, kind of, you know, in the frontal cortex. And then this is correlated with increased stimulation of descending pain modulators and increased pain. So there's something about that ruminative activity that occurs in that are very common in depressed patients that is also seen in folks with chronic pain. So so we talked about some of the difficulties in some of the commonalities on the previous slide 2 slides ago about some of the commonalities between pain patients and folks with an addictive disorder. These are some of the distinguishing features. The opioid risk tool is, this can be a helpful guide before starting opioids. It's a little less useful after someone's already on them for a long period of time, but as you can see, we commonly have patients in our clinic that are in the high risk, well into the high risk. How many times do we have, someone with a family history of substance use disorder, their own personal history of alcohol or drug use disorders, a history of trauma. You know, trauma is rampant in our communities, and or a history of depression or anxiety. It's just so common, and that constellation really puts people at high risk for abusing opioids. And that's, people try to medicate themselves, and they do what has worked for them a lot of times. It's not just about the euphoria. Sometimes it's about the relief of that psychic pain. One of the things that you can use are the 4 C's to kind of tease out addiction from your pain patients. So high craving for the substance, compulsive use. So even maybe using when they're not necessarily in pain, but just kind of using for the sake of using. Loss of control, which usually goes along with the compulsive use, and then attempts to cut down. There's usually, and this is just kind of a soft sign, but there usually seems to be a little higher emotional intensity regarding the opioid medications when you have a patient that is also addicted. A lot of times you'll have a broader amount of dysfunction in those folks with addiction. There a lot of times, things may be more chaotic in their life, whereas someone who is, treating their pain tends to be a little bit more regimented. As people with, that are successfully managing their chronic conditions need to be regimented. Routine is the friend of the person with any chronic illness, and those people who are been in treatment for their chronic pain a lot of times will not be nearly as disorganized as those people who also have addiction. And then, of course, looking at some of the aberrant behaviors that you guys are all familiar with, I lost my prescription, missing appointments, urine drug screen showing other things, marijuana, which is a real common one. But methamphetamine, other benzodiazepines that shouldn't be there, other things, early refill requests, doctor shopping, multiple pharmacies, etc. So, what deciding of, if you have a pain panel of patients that you're treating for chronic pain, and you're interested in transferring folks to MAT in an appropriate way. It's again, it requires a lot of judgment. There's no easy way, but sometimes it can be useful to think about it in kind of different groups. So you got your low-hanging fruit groups, and this is where a transfer to opioid or to MAT would make a lot more sense. Patients who are, taking opioids, on a regular basis for what are kind of more dubious indications, migraine, low back pain, without a history of surgery, neuropathy, since opioids don't work so well for neuropathy. Patients who haven't had any workup, or you can't find any, that's someone that you might want to, but are still taking the opioids. You might want to consider them low-hanging fruit, and someone that you might want to transfer onto MAT. And then in any of those patients with a pattern of aberrant behavior, I do want to state that you don't want to use, one thing as proof that someone is trying to pull one over on you, or is indeed addicted. Someone misses an appointment. That can happen with anyone. The urine, having other substances in their urine drug screen, that's more concerning. But some of the other things, can happen to really anyone. And to be fair, you probably want to see a couple of different things kind of that establish a pattern before you basically state that a person is using their opioids inappropriately. But a lot of times when you have one, if a person's addicted, if you have one, you end up having multiple. So a lot of times these folks will declare themselves. And then so on the other end of the spectrum, those folks that you want to continue with opioid therapy, and not make any plans for transferring them. Those folks with a clear established etiology of severe pathology, people with bone-on-bone rheumatoid arthritis, people with, that have had multiple surgeries and have, radiculopathy, even though opioids aren't great for radiculopathy, someone with a lot of hardware in them, those those folks are going to have more pain. And then people who have, never been, asked for an early refill, have always done well on their behavior. There's no indication that, they necessarily want to be taking the medications, but are just taking them because they help them to function, and they actually function better with the medications. Those people, you might want to put those, kind of off to the side, and maybe just kind of continue their opioid therapy. And then there's some folks in the middle, so that you might want to consider a transfer to buprenorphine, and you want to put it in the framework of, a better, safer treatment for them. Opioids aren't first-line treatments for a lot of things that people are taking them for. Low back pain, kind of basic low back pain without, surgery. So people that you might want to consider are those folks that have a very heavy psychological overlay. Not that they can't have be in that upper, that category above, where they've got bad pathology, bad physical pathology, but they're in a higher risk group in terms of using the opioids to treat their pain. And it's important to be compassionate with these folks, because they are in pain, and they're doing what they know to be helpful, or at least had been helpful in the short term for their psychic pain. But there's better ways of handling it, much safer ways of handling it. So you kind of want to have that conversation. And then folks who aren't getting better, you've had them on opioids for a long time, and they're, they're not getting better. You probably want to have a conversation with them, and they may even, a lot of those folks may fall into the low-hanging fruit category, kind of depending. All right. Using buprenorphine for pain in the addicted patient, much safer alternative. As I mentioned before, with folks that have pain, buprenorphine is generally given in divided doses. The analgesic effect tends to be greatest in the first few hours. So that's the rationale for giving it in divided doses. Even though the half-life is long, it seems that part of the of the pharmacokinetic curve associated with, kind of that upslope is the part that gives the pain relief. Rational polypharmacy, polypharmacy. We'll talk a little bit about the adjunctive medications. Use of an addiction medicine model rather than a harm reduction model. And what I mean by that is just monitoring them close, using interdisciplinary case coordination, taking a harder line on the use of other substances. There's some MAT programs that, that are true harm reduction models, and they kind of give folks that are smoking marijuana a pass because it's better than having them overdose. Keeping them alive is the first priority. But in folks with where you're treating their pain, using an addiction medicine model is a little bit better for those folks. And then minimizing the use of other CNS depressants. As I mentioned, of the 300 people that died last year with buprenorphine, I think all but just a small handful were taking high doses of buprenorphine or of benzodiazepines. All right, other adjunctive medications, gabapentin, pregabalin. You guys know a lot of this. Other anticonvulsants, particularly for some of the particular neuropathic pain, Tegretol sometimes for trigeminal neuralgia, TCAs, the SNRIs, so duloxetine, venlafaxine to some degree, NSAIDs, beta blockers for migraine, as I mentioned before, the NMDA antagonists, and then topical agents, and then of course, the non-pharmacologic interventions. So, I mentioned before about helping people to live a more ordered, predictable life. That's important to minimize stress. So exercise, healthy diet. I mean, it sounds, sometimes sounds trite, but it really makes a huge difference for folks. CBT, meditation for stress reduction, massage, TENS, CBD, that's a non-addictive substance. Of course, it comes from the marijuana plant, but it's non-addictive by itself. Acupuncture, another one. So I think that's it. As I mentioned before, there's sometimes just discussing cases in the case where there's not really clear guidance can be more useful. And I'll go ahead and open it up. While I'm doing that, I want to thank everyone for attending the webinar today. Our next webinar is going to be on the treatment of anxiety disorders in MAT patients. That's going to be on July 24th at noon.